Okay, we'll definitely review this question. Not to worry. Cool. A structural perspective of the life course model focuses on blank that are repeated or chronically activated. It's a little bit tricky. Okay. The health belief model refers to actual rather than perceived constructs, true or false. And we'll be covering this next week, talking more about the health belief model. So stay tuned. Okay. Kind of evenly distributed. Ecological models prove associations between variables and not causal relationships due to their lack of specificity. Okay, majority got that one correct. Okay, ecological models use developmental and structural life approaches to understand health disparities and formulate policy. Okay, y'all are kind of listening last class period. Dr. Anderson kind of adjusted in her previous lecture. Socially patterned environmental exposures do not influence the development of biological and psychosocial systems. True or false? Hope y'all get this one. Fingers crossed. Yeah. Mm-hmm. This was one of like my favorite questions. I think that was like submitted this week just because like it's the foundation of HBHE. Which of the following is not a perspective mentioned in life course approaches to the causes of health disparities, which was one of the readings? Developmental perspectives, structural perspectives, ecological perspectives. Okay. Blank is defined as the study of the influence of the outside environment on a person. Social ecology, ecological psychology, environmental psychology. This one was kind of hard for me when I was going through these and trying to answer it in my head. So let's see how you guys do. We'll review this one too. Social disadvantage in one generation only creates health risks for that generation. True or false? And I think Dr. Williams actually sort of commented on this in his talk in a sense. Halfway through, all right, which of the following is a critical stage in which exposure to risk or adverse events can impact health trajectories? Gestation, early childhood, puberty, all of the above. Okay, doing good. Which of the following is a weakness of ecological models for health behavior? They have broadened perspectives on causes and solutions of health behavior. They lack specificity about hypothesized influences. They focus on multiple levels of influence. None of the above. Trying to get this to go. Okay. Pretty good. So one thing that I would recommend is like as you're reading to sort of think critically about like what these theories are missing. That's something that could prove helpful in the long run too. But which of the following is not a strategy Marmont provides for closing the generational gap? To measure the problem, tackle the equitable distribution of power, money and resources, focus solely on the health sector. Reasons why public health is important. Structural perspective describes how socially patterned exposure to risk factor during life stages shift health outcomes. True or false? Okay. What is transgeneration disparities transmission? The concept that health risks are transmitted across generations. When elderly people move to retirement homes, they have worse outcomes. The concept that children pass on disease to their elderly family members. Yay! We all got that one right. Okay. For an ecological model, what kind of interventions best achieve positive changes in health behaviors in a population? Individual level interventions, environmental and policy level interventions, both of these, neither of these. And we kind of talked about this, I think, last class as well. Okay. Which of the following is not a generalizable principle when considering an ecological model? There are multiple levels of influence which impact behavior. Ecological models should not be behavior specific. Influences on behaviors interact across levels. Multi level intervention should change behaviors most effectively. What is the time point in one's life when specific stimuli must be encountered for normal development to occur called? The sensitive period, the critical period, the point of inflection, the point of no return. If a person uses a professional program to change behavior, they will not experience the 5 stages of change. True or false? Good job, guys. Okay, 2 more. The health belief model, a premier health behavior theory, explains behavior on what level of influence? Intrapersonal, interpersonal, community. I can see why you all would have thought interpersonal and community though, but we'll talk about that next week in my lecture. Okay, so developmental perspectives on the life course assert that early childhood experiences can change health trajectories. True or false? Yeah, okay, cool. Thank you all.
It sounds like they need to see this podium, so I would give them a moment to just like let them take that in. Congratulations so much to all the folks who are on the podium. They seem to have a little like stress, but competition. Also, some people are showing their bias against colors here, so we might need to talk about colorism in this class. It's really important. All right. Thank you so much, Janae, and to everyone. And I know we're running a bit on time, so I want to make sure that we have plenty of time for our guests. So let me go ahead and share my screen. Oh, I see you finally, Arter. This is exciting. Let's see. One second. There we go. All right. So again, typically you would well, now that we've kind of changed it up a bit, Janae is going to start with shorter cahoots at the top of Monday and Wednesday. We're also going to find some time to discuss answers that you all have of questions that pop up in class or that pop up from the Kahoot. But Janae also has some really good ideas about how to create environments for you all to discuss amongst yourselves as well. So we'll be talking about that in the email that's coming up on Friday. All right, that all out the way, I'm super excited to introduce a colleague of mine, Artera Rogers, and I'm going to go ahead and read some quick information about him. So some nitty gritty stuff. We're talking about a Mississippi guy, and I'm going to get to that part of what he says about himself. But everything that you know about Artera is that he is Mississippi born and bred. And so that includes his BA from University of Mississippi, where he got a BA in sociology and also public policy leadership. He then went on to Georgetown for his master's degree in health systems administration and currently serves as a fellow for Health Leads. And he has been with a number of other organizations like Kaiser Permanente and Wellstone. So I'm going to let him talk a bit more about that. But one thing I want to say is that we're also colleagues in the Culture of Health Leaders program. So Robert Wood Johnson, which is one of the most premier, I would say, health philanthropic organizations, had a call out for people across the United States to see like who's leading within their communities, who's doing innovative approaches. And I was one cohort, Artera was the following cohort. And at one point when I lived out in LA, we all had a group of LA folks who were in the program come together, and just a wonderful, incredible visionary and leader within health related care. So I'm really excited for you to hear about him. But I also wanted to share how he describes himself. So Artera says that he is the epitome of the small town guy living in the big city, growing up directly exposed to rural health issues, and now living in one of our country's largest cities. I directly see how social determinants of health and systemic inequities affect the lives of individuals living in both rural and urban environments. Based on this exposure, I've had various roles in health policy and hospital operations to advance the cause of integrating basic social needs into healthcare delivery. So if this man has social determinants of health in his bio, I think it makes a lot of sense for us to have him this week. So I'm really excited to introduce, I was gonna call you Dr. Artera Rogers. It's just in my spirit to call you that, to Mr. Artera Rogers, who will be going for a doctorate at some point. So take it away, Artera.
Hi, can everyone hear me?
Yes.
Okay, great.
Oh, I'm sorry, Artera. One other quick note. Artera's going to be, well, Artera, you can say how you would like this, but my preference is that if you have a question, we can put it in the chat. But Artera, if you want to keep going, and then if you have time at the end to address them, we can note that. But I would love for you to have your time to present. But if you do want to, stop, it's on you as well. But go ahead.
Yeah, I love for things to be interactive, so please feel free to ask questions as I'm going forward in the presentation. I thought it would be helpful, especially since you're talking about social determinants of health, to talk about what this looks like in day-to-day practice. And Janae, just let me know if you want me, I don't know if there's a way for me to control the screen or if I should just say next slide, whatever works best for you.
Yes, I can share. I've shared my screen with your slides, and you can say next slide, and I'll move to the next slide for you.
Okay, thank you so much. So I thought it would be helpful to really talk about some work around how health systems are integrating social care within the healthcare system. But I think it's important too to talk about how this is happening and the challenges we're seeing within the current context. So next slide. To do some level setting, as everyone knows, COVID-19 is the public health crisis of right now of our lifetime. And there's been a lot of conversations around bending the curve. And a lot of times that's bending the curve on COVID-19 or coronavirus cases. But what we're seeing with the economic impact that COVID-19 is having on different folks, that we're seeing this increased demand for social services. And this demand is in light of a social safety net that hasn't really met the needs of everyone who's participating within that social safety net. So with the influx of new cases, there's a need to really start to address not only the current demand that COVID-19 is presenting on the social safety net, but to really start thinking through the longer term recovery and rebuild of systems. Because what we've seen with the systems that are providing these social services is there's a need to reimagine these social services to, that was actually a good transition, Janae. You can go to the next slide. There's a need to reimagine essential resource networks to address social determinants of health. So at the organization that I'm working at currently, Health Leads, we're really taking this, I guess, two-pronged approach, working with health systems to respond now, but also really thinking through the collaboration and some of the root causes that have created these inequitable networks to create more crisis resilient, sustainable, essential resource networks. And how do we start to share that learning and the data between different social safety nets, as well as healthcare systems who work in the margins as well. And to give you some context of why Health Leads does this, Health Leads is an organization that was started and founded in Boston, Massachusetts. I'm currently on the California team. I serve as director of programs for the California team. And we have a approach where we do local place-based work, and we use the findings from that local place-based work to start to innovate with different hubs across the country around addressing social determinants of health, typically within healthcare settings, but we're seeing even more so with COVID-19 to expand beyond that, to look at education, the public health departments, and others, because we believe that a collaborative approach is needed to address social determinants of health. Next slide, please. What we are really focusing on in our work now is this move towards racial health equity. And in doing that, we're really talking a lot about community health aims, caregiver workforce development, and then data democratization. So with the community health aims, it's really discussing and focusing on shared power. So we see within our healthcare system huge disparities, typically along lines of color, but we also see that in other characteristics as well, as far as gender, sexual orientation. And what we feel that we have to push, and when I say we as Health Leads feel that we need to help healthcare systems really focus in on, is partnering with community residents, particularly the affected populations who are experiencing the most disparity, as well as community-based organizations who explicitly partner with the affected population to begin to develop health goals together. Because we're seeing that in addressing social determinants of health, what makes a person healthy is not just limited to their access to care, but goes beyond to think through the environment, their socioeconomic status, and that lack of integration between addressing the other components of what it takes to be healthy and just looking at access to care. I believe has led us to having these gaps. Then we also talk about sustainable caregiving. This really goes to the importance of uplifting people who are caring for the most vulnerable, but are doing it a lot of times with either no pay or below a living wage. So if we really want to see the most vulnerable or the most historically underinvested and underrepresented communities uplifted, we're going to have to give a living wage and even go beyond that to the workforce who probably is most equipped to help address some of these health disparities. And then we often see, particularly with communities of color and other historically underrepresented and underinvested populations, that we extract a lot of data from these groups, but we don't partner with these groups to interpret their data narrative. We don't work with these groups to talk about what does this data lead us to do next. And we want to change that. So really thinking through data democratization is another level of focus for us. Next slide. Okay. So, and we can keep going through this. I'm sorry for the animations. So I really want to talk about why we have started to take this approach. Healthlease, just like so many other healthcare organizations, you know, we have to admit that we've been part of the harm and participated in systemic racism as an organization that is typically white-led, and oftentimes have had to work to have people within the organization to reflect the communities and populations that they're trying to serve. That's something that we're getting better at, but we still have work to do. So I want to reflect on how some of our old work has allowed us to have the approach that I just talked to you about today. So I'm going to talk about a partnership that Healthlease has had with Kaiser Permanente, particularly the Southern California region. So if we go to the next slide. So many healthcare systems are looking at how do we address the needs of the most at-risk populations. Many healthcare systems develop algorithms that either predict high utilizers or denote who a high utilizer is within a particular system. And a lot of insurance companies really look to see what type of interventions, typically these are case management or care management solutions. How do we address the needs of the high utilizers? So this algorithm that we looked at the DSCG, which is just a medical risk score, as well as the segmentation work that Kaiser Permanente had developed, and applied it to all the Southern California region. From there, that algorithm predicted for the next 12 months who would be the highest, who would be the top 1% of high utilizers within that region. And the thought is if they're using the most care, they cost the most money. So this, even when we talk about social determinants of health, as we look at it as a community good, community benefit, there was a desire to understand what's the return on investment in addressing social determinants of health. So we'll go into the next slide. There was an intervention that ran between November 2015 through March 2017 that looked at a variety of social needs ranging from health literacy to food insecurity to social isolation, caregiver support. There are about 14 needs that we developed a customized social needs screening tool for, really pulling from literature to make sure we're having validated items on that screening tool. Next slide. And the approach was to have a regional call center where we would proactively, as a health system, screen these predicted high utilizers and understand if connecting people to essential resources actually improved utilization. So that was the premise. Next slide. So ultimately, the flow of the intervention, there was the screening tool. If a person screened positive, we would offer enrollment in, I would look at it as more of a community health worker model where someone would be able to walk them through and help them connect to the resource that they felt like was of importance to them. There was follow-up about every 2 weeks until the person was able to connect, or there was a disconnection. So this was a telephonic case management program or care management program, or we couldn't actually connect a patient to the resource. Next slide. And from that, we did a pre-post evaluation. We targeted certain number of patients based off of power calculations that were developed by our research and evaluation team. We looked at everyone who entered to the program. If you received a phone call, we looked at you as intent to treat. And this was done by a difference in differences analysis. We also did some subgroup analysis and some latent class analyses to understand this patient population more after the fact. So that's just an outline of the research approach that we took. And what we were looking at as far as metrics included inpatient, thanks so much for that, Rihanna. Inpatient, emergency department, and outpatient visits. We also were interested in costs. I'll give a little bit more information around that. And then we also looked at how the patients flowed through the actual intervention because we wanted to actually get some feedback from the patients and the providers of the intervention. Next slide. So this is just a descriptive table of the individuals who participated. What I will say is that the participants tend to be older, so the predicted high utilizer model showed that older people were more likely to use services. We also saw from race and ethnicity standpoint, we have a higher white population within the KP market, Kaiser Permanente market, so that's reflected in there. But what was really interesting is, especially for the Black population, Kaiser Permanente does not traditionally have an overwhelming number of Black people within their insurance market. It was very interesting that the intervention group had 25%. Most of the individuals who went through also were Medicare, and this goes to the fact that this is the older population. And we see various comorbidities that were present within the intervention group. Next slide. So as we're going through looking at how people went through the intervention, what was really interesting was that although 55% of patients who agreed to be screened actually had a social need, only 40% of the patients reached by phone had a social need. And I can go through that. So what we saw was a significant number of patients identified as being a predicted high utilizer. Well, we started to see voltage drops, as we described them, going through the intervention was each step through the process. And so the part of just answering the phone, that resulted in a drop. Then we saw that individuals who accepted a social needs screening, some screened negative, so that resulted in a voltage drop. But even the group that we looked at who screened positive, what was the most interesting, and this is kind of column 4, when we look at the enrollment and navigation, we had almost half or over half of individuals declining service. And I want to bring that up because whatever you decide to do, if you're working with at-risk populations, this is process metrics are really important to understand if you are actually reaching the group that you want to reach. This is one of the earlier interventions that I worked on. The recommendation to myself is when we see data like this is to pull up and to start looking at some of the root cause, doing a root cause analysis of why this is happening. So we did that, but it was later on. And we started to understand that we had digital divide issues. We had issues of when we're reaching the most at-risk patient population, looking at phone numbers change often. We had to start talking about access to a phone. And these are things that when you are looking at, again, at-risk populations, that you continuously have an improvement cycle within your intervention work to ensure that you are reaching the group that you're wanting to reach. So with half of the individuals who even screen positive declining, and looking at column 5, we see that we had a significant amount of people who had some type of connection, meaning that information was given to them or people actually connected to the resource at hand, and 23% had no connection. And I'll go through that a little bit more. So next slide. As we looked at what social needs were of highest prevalence, we saw that so many things were rooted in financial strain or socioeconomic status. And the things that were kind of alarming from that were looking at the amount of hunger that was present within the KP community, also looking at the need for utilities assistance and social isolation, which is something that was not at the top of the radar for the KP health system, particularly in Southern California. But again, doing this type of screening allowed us to understand some of the social risks and the environmental factors that these patients were going through to connect to services within the healthcare system and outside the healthcare system. So I want to stop at this point to really state that when we look at these social risks, there was an article that came out from JAMA that talked about the ethics around screening for social determinants of health. It's become extremely popular. What we really started to see, though, was some malpractice in screening around social determinants of health, because there was a belief, or there is a belief, and I actually agree with this, that if you're asking a person about a social determinant of health or social risk, you need to have some type of resource that you can connect people to, or try to connect people to. Again, this goes to this extraction of data that happens predominantly to communities of color, to more historically underinvested and underrepresented groups without any type of return. So I just wanted to uplift that point here. Going to the next slide. So where things became really interesting, started to look at understanding the successful connections. So there were about 8,399 needs identified. Now, 4,274, again, that goes back to the previous slide where we saw half of people enrolling. Only about 4,000, about half of those needs came into the program. What we saw was the majority of those needs actually were not addressed because of the telephonic model. I think a root of it was because of the telephonic model, where we saw 3,000 of those needs actually being disconnected. Whether they went through the program and they were not able to connect to a service that benefited them, or the community health workers really lost touch with the patient. We saw about 249 needs being confirmed that, hey, we were able to receive a resource. And the 412 and 413, so the 825 other needs that received some type of navigation, it was more they were able to receive some information, or the patient said that they had enough information that they could proceed on without the community health worker. So we were not able to track that all the way through. Now, looking at this, with only 6% of needs actually having a confirmed connection, I would think that there was no effect on the population that we were looking to serve. Going to the next slide. Looking, before I get into the results, sorry, I forgot about this slide. The most referred organizations, or the most successful organizations, actually had a notable automated process. So it really was easier for the patient to navigate within that system, getting that resource. And I'll talk about why that's beneficial, hopefully a little later on. So next slide. Okay, so we started looking at some of the subgroups, and so we began to look at patients at a census tract level, because Kaiser Permanente is very fortunate that they have this type of data that they're able to look at a patient within their census tract. And what we were able to see with individuals who came from a low-income census tract, that we were able to see a decrease, a statistically significant decrease in utilization of services. What was interesting for the low-income census tract was that we saw actually a decrease in inpatient admissions, which without further context seems great. Going to the next subgroup, so next slide. When we look at the low education census tract, we saw a decrease in utilization, but we were actually able to see that more from out-of-network total visits. And this is why this is particularly interesting and fascinating to an insurance provider, is that this really shows that with this program, that people were able to navigate the Kaiser Permanente system better. So this saves them money, but what we really saw with this is that having this additional assistance allowed for people to remain within the system and to actually navigate the system better. Next slide. And we also saw that with Medicaid patients and dual eligible patients. We lumped them together, and we were able to see, again, a decrease in utilization, mostly from out-of-network care. Next slide, please. So I was talking a little bit earlier about how people were flowing through the intervention and why I thought that was important. And this slide right here highlights why this is important. Because although we were able to see decrease in utilization, amongst some subgroups, we were not able to see that for the full sample. And I'm going to get into some reasons why I think that that occurred. So next slide. We can go to the next slide, Janae. So we conducted a latent class analysis, and there are some things that I wanted to highlight. So a latent class analysis is basically this computer-generated method of being able to put people who have similar characteristics and put them into groups that are statistically significant from one another, or statistically significant. There's this statistically significant difference between each group. And I'm not a latent class analysis expert. I just know what the output was. So looking at all of the patients that were in the intervention group, we saw 4 classes emerge. So class 1 had the most social risk factors, and class 4 had the least or the fewest social risk factors. What became really interesting was that the group with the most social risk factors actually was the youngest subgroup. You had a significant or had the highest proportion of um, Medicaid coverage and actually the lowest amount of Medicare coverage, which becomes significant as we start to look at how people, um, how people get benefits. So we see Medicare patients actually being eligible for more things sometimes than Medicaid patients, and the comprehensive care coordination around uh, Medicare populations typically is better than Medicaid populations. And I think that's just a flaw in the system because they actually come from CMS. A lot of times we look at CMS as just being Medicare, but it is Medicare and Medicaid. And then we see a higher population of dual eligible or higher percentage of dual eligible patients within this group. What really blew everyone away, and especially thinking through this time, was the percentage of Black people in this group. And when you look at the number of Black people coupled with um, the Hispanic Latinx population, you're starting to see the same trend that we typically see within a lot of racial health disparities coming into a social determinants of health space. So you're seeing as the classes, not only as the classes are getting older, you're seeing fewer social risk factors, which was actually surprising. But as you're looking at the Black and brown population within this group, the higher Black and brown population within a class, the more social risk factors that you have. And this really caught the healthcare system's attention when we look at the next slide. That shows that the total utilization for class 1 is it's a statistically significant difference between class 1 and class 4. And when we look at just 5.5 versus 4.3, and this is kind of number of visits, that may sound like a small difference, but when you have a visit that can cost tens of thousands of dollars, we start to really see how this proves a return on investment case or a value case for social determinants of health. And when we started to look at this from a resource connection standpoint, we started to see, looking at the latent class analysis, how the resource connection really provide an opportunity for us to improve on the intervention. And I know that I'm running out of time, but that really allowed us to then focus on doing some CBO interviews, because we needed to understand how do we create more automated processes between efforts that the healthcare system is doing and the efforts that community-based organizations within the community are doing, because we're actually touching the same patient population. So I'm gonna stop there. And if folks have questions or comments, I don't know if people are able to come off mute, Rihanna, or if I even have time for questions.
Yeah, so feel free if you have a question to come off of mute for our chair. And I just want to acknowledge, again, from an applied standpoint, our goal on Wednesdays is to talk about the application of some of the theories or the models that we're thinking about. So my hope is that you were able to see from our discussion on various systems or structures or elements of the ecology, like how much that impacts the quality and the reception of care as evident from this study. So other questions, thoughts, or comments for Arter while you have him?
Thank you, Arter, for the presentation. I was wondering, I know you said you were surprised to see the age increase as the social risk factors decreased. Do you possibly have an insight as to why that is? And maybe if your company looked further into that?
Yeah, so great question. Again, when I started talking about the support that Medicare patients are able to get versus Medicaid patients, we were seeing the case management programs that these patients were already in. And honestly, as we started to do some of the more of the qualitative work with interviewing patients and understanding what their process was like, people in class 4, which has the higher age but the fewest social risk factors, that group actually had more support. So they often came from more affluent areas, often had individuals who could take them via car to connect to a community resource. While one thing that I didn't really point out in the late class analysis is that the class 1 actually had 4 more risks every time. So the quantity of social risks that they had to address and tackle was, even more significant than the class 4 who had the fewest social risks as well. I hope that answered your question. So, case management coupled with the number of risks that were present within the classes made a big difference. And again, looking at the census tract data to see, what type of environment that they're in gave us an insight as well. Being able to see that there were just more resources within a given area versus some of the resources that were present or not present within the class 1 patient population.
Yes, thank you. That makes much more sense. Thank you.
Hi, I really loved how you mentioned like the ethics for screening for social determinants of health. And I was wondering, how do you know when enough is enough? Like, you don't want to just, give somebody a pack and say, here's some resources, but what point do you think that like ethically you've fulfilled that?
Yes, so great question. We had a standard of how many times we had to reach out to a patient before closing that case or calling them disconnected. So this was 4 times. And that's 4 times of no response. And the reason why we did that kind of goes to what you were discussing, that one, we wanted to pursue the patient as much as possible without being a nuisance to them. So that's a boundary that we had to talk about. And then we also had to really navigate some of the more challenging social risks. So talking about housing, and I'm sure Rihanna can really affirm this housing crisis everywhere, but it's really noticeable in Los Angeles County and the surrounding counties as we talk about housing displacement as well as homelessness itself. And so we had to really think through what are the services that we can provide when we could only give a referral to an organization where we know that there's an extremely long wait line. A lot of times housing is coupled with other needs like food insecurity as well as financial strain. So how can we address some of those needs and continue to go back and forth with them around housing to make sure that they at least feel like they have enough information to connect with the individual at that given community-based organization.
Thank you.
Can I ask a question?
I'm so sorry.
No,
really,
it's okay. Don't worry.
But we'll make sure if there are questions for Artir, we can get them to him and maybe he can respond in a bit. But we want to thank you so much, Artir, for your wonderful insight and your application of systems and social determinants of health to the real world. Thank you so much, Artir. We'll hopefully have you soon and we'll see you later.
See you later. Thank y'all so much.
Claps. I just want you to see that you're getting claps all the way through. Yes.
Oh, thank you. Thank you.
Yes. All right. Well, take wonderful care. Talk to you later.
Talk to you later. Bye.
Okay. All right, folks. We are always pressed for time, and I'm so sorry about that. It's just so good to hear wonderful folks and to navigate Zoom as we are figuring out the timing of that. So we're going to transition a bit, and I won't show these slides today, but when you do have access to them later in the week, you'll see just some videos and some other like levels and ways that we talk about systems and social determinants. I do just want to make a quick point for this reading, the Reskin reading, something that I believe very deeply and is not a focus of this class per se, but of my work and of a lot of the scholarship coming up is how racism, and it's marked here as discrimination, which is more of the interpersonal behaviors, but racism as a system really is the thing that drives all of these different systems that we think about that impact things like Artir was talking about. He indicated racial or racism as a impediment to some of these other systems that go around. So when you're thinking about systems, I don't want you to think about them in silos, as in, you know, the external systems all rely on each other. They're really racism at the center that's driving this inequality in the systems and then in the care that we see here. So I just wanted to focus on that one point for this Reskin article, but always happy to talk about more at another time. Again, more videos and resources on the slides that we won't be able to get a chance to go to today. Okay, so I want to talk about Twitter, which is both homework-based and the activity that we're going to engage in today. So Twitter, a thread, that's kind of tongue-in-cheek for those of you who use Twitter, but we'll get to it in a second. Okay, dang, Dr. A, why are you all about this Twitter thread? Aren't there other social media platforms? There are. So a quick poll, which I'm not going to throw up on the screen just for time purposes. So you can go ahead and throw it in the chat. What is the social media platform that you use the most? So put IG, Twitter, or I know y'all don't use Facebook like that, but FB. And if it's TikTok, go ahead and put TT. How about that? So something indicating your favorite social platform. Wow, that went up super fast. You all are quick. Okay, Instagram, great. Twitter, okay, one Twitter. Okay, cool. IG, overwhelmingly IG. Fantastic, which is why I wanted to have this slide here. So why the Twitter? Twitter versus Facebook versus Instagram demographics all differ. So by and large, about a fourth or a quarter of all folks are on Twitter, a third are on IG, but again, based on your demographic, it's clearly overwhelming that that's the platform most used here. And actually 70% of the US adults are on Facebook. So if we're just going by the numbers, Facebook is actually the platform that if you wanted information out, you can target the most. But it's about who and why folks use it. So again, younger demographics typically go to Twitter and IG. And then the one thing that the one thing that I wanted to say about the engagement. So sometimes it's not just who's using it, but how they're engaging with it. So Twitter users are on there virtually every day. About 81% of people are on Twitter every day. I would have thought that IG was a little bit higher. The article is hyperlinked in here if you want to take a look at more of those demographics, but it suggests that Twitter is one of the most highly checked and engaged with social medias, but also how people use it. So 74% of Twitter users say that they use Twitter to get their news. And in fact, one quick story is that when I was in Virginia about a decade ago, there was an earthquake. And so I was looking around like, why is my desk shaking? Like for whatever reason. And I saw someone run under a desk and I'm like, why are they under a desk? They pull open their phone. I was like, what are you doing? They're like, I'm checking Twitter to see if there was an earthquake. So that it is a way that people quickly engage with what is happening, what's the news. And I often find out things on Twitter before I do the, the local or national news. So again, people are checking into Twitter as a source of news versus what IG is, which is often photos or social activity, and Facebook, which is a lot more family-based or like sharing of articles that have already been written. Okay, so what I would love for us to do is to think about some of the models that we've learned about this week. So the social ecological model or the life course perspective. And I want you to depict how the social determinants of health are most related to mask wearing. So pick some element of what we've talked about this week with respect to systems, social determinants, developmental perspectives, and think about, again, if folks are or are not engaging in the behavior of wearing a mask, what do we know based on that model or based on that theory that's going to let us know how to target that population? And I want you to break up with your group members to encourage Twitter users in particular to wear a mask. So we're talking about younger people, we're thinking about people who check frequently. We want to engage with them based on our knowledge of the model or the theory, right? And based on what we know at this point, I want you to think about how you can engage Twitter followers to wear a mask. So the things that you want to consider are that there often are contemporary, useful, and select hashtags. So you don't need to focus on that as much today because we don't have a lot of time. But just to be mindful that that's an aspect of when you turn in your homework next week that we'll be looking for. The length of the thread. So some people write threads that go on 20, 30 tweets long. So a thread is a connection of ideas from one thought to the next. So you don't want it to be too long, so maybe limit it at about 5 tweets, but know that you can get a lot of information out with a thread like that. And then the appropriate @ is there organization, is there, like Arter is coming from Health Leads, for example. If his organization just presented to us, we could say, Arter from @Health Leads just talked to us about the strategy. And so thinking about who you want to pull into the conversation as an @ is also a way to engage with folks. I'm gonna stop the share and I'm gonna send this is gonna be so tight on time and I'm sorry that we keep doing this. I'm gonna really try to get our timing a bit better. So I'm going to drop this document into the chat right now so that you can see some of the things that we'll be using to, sorry, there we go. We'll be thinking about some of the elements that are in here. So you'll see the Twitter kind of information that I just had hyperlinked on the screen. And I also included a thread that I wrote, which was about 10 tweets long, but I created a story from it. And I was able to say like, so because of this, or like building on the last thing. So I'm kind of giving you a story and not just putting together 5 or 10 different types of ideas. So I just wanted you to get a sense of what that looks like. Uh-oh, sorry. Okay, 1 second. You do need to sign in with UMich email, but it looks like that might not be open for everybody. So 1 quick second. Sorry, this is taking a bit of time. So, you know what, it doesn't look like, okay, it looks like folks are able to get on it. At least I see you on there and it looks like you all can view. So let me at least change the view to, well, no, I want to keep it on view. Okay, so I'm not sure we'll have enough time to break out into groups. And again, we're working on getting the timing. So that's on me and I apologize for that. But let's kind of just talk out loud beyond these 3 things that you're seeing there. So the things to consider: contemporary, useful, and select hashtags, length of thread, and appropriate @. What are some other things that you might want to consider when you're creating your narrative about how to, or the, like, why to wear a mask, what things you would consider for telling people about masks, given the knowledge that you have of ecological systems, given the knowledge of challenge between like steps of telling people what to do and them doing it. What are some of the things that you think would be important right now? So you could go ahead and come off mute if you have some ideas.
I would pick resources that were written very simply. I wouldn't necessarily link to like an academic journal. Make sure it's a website that everyone can access for free and that explains information thoroughly, but also just as simply as possible. Maybe some diagrams, things like that.
Yeah, that's really helpful, Carly. So an infographic or something that'll allow people to see something very clearly without having to go in depth. The example of the thread that I provided did have my academic articles, but it was, that day was one of the blackout days that people were supposed to be looking for information for racial injustice. And so I was like, if you're looking for it, here's a completely academic thread. And then I also had, do you want like media resources? Here are videos that we've developed. And then I said, do you want like simple and plain resources for schools? Like I had 3 different ways for people to engage in the research. So that's a great point, Carly. Anything else that's important to consider when you're developing your own thread?
So just like Carly mentioned, something that's visually appealing, which I think a lot of Instagram users, you know, when they're reposting, that's one thing that catches their eye, and like small bullet points that like get to the point, but you know, make a bold statement.
So that's a great, I'm separating those out. So visually appealing, and I put Canva on there because if you have not used Canva, then you're going to see that they have a lot of templates already for, mainly for Facebook or Instagram, but we always use our products across the different platforms. So it's really important to think about that. I also said bulleted. So why don't we put that with simply written resources? So simply written and then visual as well. Simply simple visuals of the words as well. I see Emma, is your hand raised? Was that for?
Yeah.
Okay.
Oh, I just had another like point, like thinking about the social ecological model, and maybe including like organizations or resources that connect to what you're tweeting about.
Okay, Emma, I have to apologize. I was reading, listening, and typing, so I missed something. So Emma, say that one more time for me.
Yeah, no, it's okay. So I was thinking about in terms of the social ecological model, thinking about like the interpersonal and community and organizational components and what resources or even like regulations might be important to note in terms of whatever you're talking about in your tweets.
Right, so I'll broaden that a bit, right? So for the theories or models, consider I guess the parameters around it, right? So next week when we're talking about health belief model, which is gonna be tied specifically to more of the intrapersonal, right? That was the question that you all had on Kahoot. So what is it that I am doing as an individual that's gonna be relevant for this? It wouldn't make sense then to take a lot of the community-oriented context for that specific type of tweet. So you want to think about who your user is, and with respect to the theory, if you're going for the individual, like stay there, stay in that lane, relative if you're like talking more about a community or an organization. So that's really helpful, Emma. Maybe one other thing that would be really important to consider.
Sorry. I was just going to suggest that like stats are super, I feel like, effective, like when you're just concise and you throw out data in like a good summarized way. And like I have found that I particularly enjoy when it's just like a simple stat with like a link attached to it. So then like you read something, it makes the impact, but then like you can read further into it and it's just like easily accessible.
Yeah. Now, I know we have like 3 people trying to jump in, so let me answer a few things in the chat. Also emphasize Maria's point as well. You can use other visuals. So right now there's a Twitter chat that I'm like going on in a few minutes as soon as we jump off with rooters. And for those of you that helped, amazing job. You all did amazing work. So we're taking infographics that like CDC and NIH and all these folks who have already created and putting that and saying like, given what NIH has said about this, given what CDC at the beginning of this pandemic, when they had sense, said about this, like this is what we're linking to, right? Relative to having to develop everything your own. So absolutely beg, borrow, and instead of steal, acknowledge, like act them and say like, this is their product. You can also tag them in the picture so it doesn't take up part of your 280 characters. All right. Lauren, it looked like you had something.
Yeah, I wanted to add on to something with stats. So I had to develop a material for the county to educate about drug use. But one of the things that I learned through that was that you should have your stats be consistent. So like instead of saying 23% of this and 2/3 of this, and you know, it should all be as much as possible, 23% of this and 46% of this and 50% of this. And also to have the stat first followed by the rest of it so that people see that stat and then immediately what it is instead of reading a lot of jumble around it.
Excellent point. Great. And so I'm also throwing the point of being mindful of the politicization of what's going on right now. So in terms of how you word things and who you're appealing to, being really mindful of that as well. So these are great points. I know we're at time. It's 2:20. Not my intention to not have you work together today. So maybe Janae and I can spend some time thinking about how on Monday you'll have a bit of time to practice before submitting this on Wednesday. But I hope this was at least a good start. So now you have an idea of what a Twitter thread looks like. So there's an example. You have some things to consider as you're putting it together. At no point are you going to have to press send on a tweet. So I do want to say that very clearly. At no point when we're doing the op-eds, the videos, any of this, are you going to have to submit it? That is not the intention, but to develop it and to create it is the goal. But if you want to create even a play Twitter account, just so you can see how things hashtag, see how things add, see how you can upload something, that'll be a lot more helpful for you to get a visual. So I would encourage you, if you don't have a Twitter account, just to create, it could be, you know, 1, 2, 3, 4, 5 cat, like literally whatever you want it to be, but with the intention of not submitting, right? Okay. It's 2:21, so I'm going to, yeah, if you do want to submit it, just wait until after the submission. But again, totally your choice, absolutely not something you have to do. Alex?
Is the assignment posted? Like, I don't see it on Canvas anywhere. Is that a thing?
Yeah, so Janae posted the assignments. What we're gonna do is comb through just to make sure the links aren't broken or anything of that sort, but it should be under assignments and it should be something that you should be able to submit either through a doc or an upload. So let's let Janae and I comb through. So if you have it completely finished and you're a G out here, fantastic. But just hold on to it and we'll submit more Thursday or Friday with our email update. Is that okay? Thumbs up from folks, if that's okay. All right. So yeah, Janae did post it though, so we'll figure out what is going on. All right. We were supposed to practice today, Lauren. Time got to us, but we are going to try on Monday to practice as a group. You will submit everything individually up until the final assignment, which we'll talk about when we need to get to that point. All right, I know folks have to go, so if you do, please feel free to go. But first question, as you know, for always, what's something that you learned today? Second question is what, or how do you plan to apply this to your life? And then head on out when you're ready to roll. So question 1, what did you learn today?
I learned that about the consideration of ethics in data mining and stuff. It totally makes sense. It's just not something I heard before in the conversation around health disparities, and I thought that was really interesting.
Thanks so much, Alex. How about what you're going to apply to your life? What's one thing? Carly indicated, considering how social media works and what platforms which could be used to reach what population. So again, even with our TARES talk today, it was probably a bit highbrow to take some of those bigger statistics or like the latent class analysis. Like that's something that I know very well, but that might be a bit too heady to throw on a platform like that. But some of those really cool findings to me of how from one kind of bucket to the next, there was such a drop off in participation or getting the needs met. So learning how to take that and say it simply and create a simple visual around that can even take a 30-minute presentation like what he did and make it applicable in a series of tweets. Okay, so I don't want to hold folks. We will try to practice this. We'll get our timing together. Thank you so much for hanging on today. We'll address all the questions that you've left. And we'll talk with you next week. Take good care and find out more information about the strike, as I see a lot of people have in their background images. So if you want to kind of move out the side, Janae and Shiva, just a bit so people can see that if they need the short link. Okay, have a great day, y'all. Thank you so much.
Hey, Professor,
Yes, ma'am.
I have one last question before you go. So
Yeah.
where can we find on Canvas the PowerPoints from previous lectures?
So let's see, Janae, Janae looks frozen. Oh, there she is. Okay. It should be in the modules and then by week. Yes.
I'm sorry, what was the question, Dr. Anderson? I heard my name, but my computer froze.
Yeah, where to find the PowerPoint. So it's under modules, yes, by week.
Because the last one I see is from I think the 9th maybe.
Okay.
Because I was looking for last week's and looking for Monday's lecture.
All right. Oh, so I use the same PowerPoint for Monday and Wednesday, like the same full PowerPoint, and so I only upload it once a week. So this week's the one for the 9th would be the latest one posted because it's both it would have been the week of the 7th, so it would have been the 7th and the 9th. So today or tomorrow, I'm gonna upload the one from this week.
Okay, perfect.
Okay.
All right, thank you.
Thank you. All right, lots of other folks. What's going on?
I was just sticking around to type in the chat that I really love the Kahoots and they're awesome. And I've been using them to review. So
fantastic.
Thank you. Okay, bye.
I love that. Thank you. Bye-bye.
I have a question about like the Twitter thread and then also like the lit search assignment.